Ready.
Good afternoon, everyone. My name is Rosa Mendoza, and I'm the president and CEO of Avanza. I'm so glad so many people could join us today for what I know is going to be a fascinating conversation about how next generation innovations can empower the Latino community. Before we begin, I want to acknowledge LULAC and Cindy Benavides for their partnership. We are so grateful for your collaboration and support. We have seen how innovation can transform every aspect of our lives, the ways we work, learn, communicate, and interact with our friends and neighbors, even the way we seek treatment and receive medical care. As with other aspects of technological change, the benefits of innovation in medical research and care are not always shared equitably. Rapid innovation allows doctors and hospitals to offer unprecedented levels of care, even over great distances. But access to affordable healthcare remains out of reach for many people. Avanza is dedicated to ensuring that Latinos and other underserved populations benefit from next generation technologies. And we are encouraged by emerging innovations in the ways they can empower Latino communities through educational and economic opportunity and improved health outcomes. And we continue to ask important questions about the challenges that come along with the benefits of technological change, and continue to work with all stakeholders to find ways to prepare underserved communities for future changes and challenges. And that is why I'm so excited about today's conversation. And here to talk about these important issues is our all-star panel and our moderator. Carolyn Sanchez, Innovation and Technology Committee Chair, LULAC National. Carolyn, please take it away.
Thank you so much. It's great to be here with such great panelists and their expertise in an issue and a topic that's not only so important to everybody's lives, but near and dear to me in my life and journey. A little bit about myself is so that you get to know why I'm here, and I was so happy to accept the invitation. Thank you, Cindy, for asking me to sit in your place. So my name is Rosa says, Caroline Sanchez Crozier. I'm based in Chicago, and I recently have this new role with LULAC. Over the many years, 30-some years that I've been with LULAC, I've had I wore different hats, both locally in Illinois and now nationally. But we are volunteers. As a committee chair, we are volunteer experts in the different areas. And in my case, this is in technology. My day job now is I've been a 33-year entrepreneur, as they say, 1% Latina business owner in STEM. The founder and CEO of CSC Consulting Group, based in here in Chicago, as I said. And as I said, I was a pioneer in technology. I really grew up with technology half my life. Started with Apple as a partner, and with primary client being the Chicago Public Schools, the third largest school district in the country. We fast forward today, we still serve the Chicago Public Schools, but now with Cisco is one of our partners, and we provide Cisco engineers and support the internet infrastructure. And we also provide, as an MSP, we serve nonprofits and small businesses. But besides that hat that I wear in LULAC, I also recently in 2019 founded a nonprofit called Latinx Digital Leaders Now. It was actually a year before the pandemic, and it was to address digital equity for Latinos. And now with the pandemic, it's become essential. And as we say in LULAC, is the current civil rights of not a decade, a century. So this topic is very near and dear to my heart, and I'm honored to have these great panelists before me. But before we start with questions, I would like to ask each of you to give a little bit background of yourself in this particular order, so we get to know how you will be contributing to these great questions and conversations. So the panelists before me are Mike Ibarra, Emergency Physician and Vice President of Strategic Alliances and Chief of Medical Affairs for Pharma. Cristina Carles, Vice President of Global Marketing, Digital and Innovation for Gilead Sciences. Robert Branson, President and CEO of Multicultural Media, Telecom and Internet Council. And Juan Leonardo Negron Diaz, Public Policy and Communications Director, PR Latam at Merck. So in this order, if you may, please ask Mike, Cristina, Robert, and Juan, give a little background of yourselves, please. Mike?
Yeah, absolutely. Thanks so much. I really appreciate the opportunity to be here. Can you hear me okay?
Yes.
Awesome.
Yes.
Always got to do that check. Video's on, sound is working when we're on Zoom. So it's a good start. Thanks for the chance to be here. As you mentioned, I'm a vice president of pharma, and I'm also an emergency physician. I'm here in DC. That's where I work, both at pharma as well as clinically. And it certainly has been an interesting 2 years, to say the least, working clinically in the ER throughout the pandemic. Started seeing patients back in March of 2020 with this strange respiratory disease, COVID-19. Although I suspect I was probably seeing it before then, we just didn't quite know until we started really tracking cases closely. I've learned so much in the last 2 years with a really steep learning curve in the first 2 months. I remember one of my first memory was, ordering tests on patients that I suspected of having COVID-19 and waiting weeks for the results to come back. The first test I ordered took 21 days to come back. Long after that was at all relevant. Of course, the next shift that I worked, the test took 14 days to come back, and then 7 and shorter. So the patient that I saw first actually had to wait the longest to get a test result back. But at the same time, from an industry standpoint, working in the pharmaceutical industry in my day work and then my clinical work in the ER at night, this has really been an unprecedented response to the pandemic. I feel like I've had a bird's eye view into how industry views the COVID-19 pandemic and the lessons learned from that. I think it's really clear that the COVID-19 vaccine and therapeutic development was really an unprecedented success. While some of the reasons for that success may not be replicable in normal times, so to speak, outside of the pandemic, there are a number of things that we can learn about vaccine and drug development and the delivery system that administers them that we can try to adapt. And I want to hit on a few things that we can double click on throughout the course of the conversation that I think are particularly relevant both to LULAC and Alvanza. And I want to also would be remiss to not start by thanking you for hosting this important conversation. Those buckets of potential lessons learned are so extensive. There are so many things that we can and should have learned from the pandemic. But as it pertains to industry, I think a few that I would love to hit on over the course of the next hour or so are diversity in clinical trials, something really, really important to folks on the line as well as to industry. We've known for a very long time that inclusion of individuals with different demographic characteristics really helps us improve the completeness and quality of clinical research, and we have to incorporate that. That is a lesson that we knew before the pandemic, but it's something that we really focused on in the pandemic, in part because some of those first patients that I saw with COVID-19 were disproportionately from minority communities, families that were impacted by COVID-19. And there's a variety of reasons why that was that we'll certainly talk about. And so that's why diversity in clinical trials and having a real keen focus on that is so critical. But in addition to diversity, just general public awareness of what a clinical trial is, why someone might want to participate in one, as well as public communication about research and science. There's been a whole infrastructure built up around administering vaccines and talking to people about COVID-19 vaccines, therapeutics like monoclonal antibodies. And we need to continue investing in that infrastructure because that has applications outside of COVID-19, things like cancer, diabetes, diseases that disproportionately impact minority communities as well. So I know there's a lot to unpack over the course of the next hour. I really, again, appreciate the opportunity to be here and look forward to discussing with you all.
Thanks, Mike. I'll go next. And thank you very much to LULAC and Alvanza for having this panel and for including me as well. I'm from Gilead Sciences, so I lead digital innovation, which you can imagine, only accelerated over the last, 20 months because of the pandemic. And Gilead is a company that's been around, since the early days of the AIDS epidemic, and our focus has really been virology. And now we're branching out into oncology and other therapeutic areas, but one of the, we also played a critical role did our part in the COVID-19 pandemic with remdesivir. And, remdesivir is a product that it was no accident for Gilead to have it almost, handy and ready to go because of our legacy in virology, our understanding of viruses and the legacy that the company has in really advancing, science and understanding of viruses. As part of my leadership at Gilead, I co-lead Gileados, which is the the employee resource group or business group that supports Hispanic and Latino employees. And a big focus for us this year has been driving health equities. So how do we make sure that our products get not just to the people that can have access so readily to our medicines, to healthcare, but to everybody, and especially to Latin communities? How do we build that trust? How do we continue to build partnerships? And I think touching upon what Mike said, I think a big priority for me and a big lesson from the pandemic was actually collaboration. It really takes a village. It really takes all of us working together in all parts of healthcare and policy to drive that equity, to ensure that we have health equity amongst Black and Brown communities. And that I think it's a big lesson from the pandemic that I hope we can continue to leverage and march on, as we move forward. Robert?
Yep, I guess it's up on me now. And first of all, let me also say thank you for the invitation. I appreciate the opportunity to express some views. Let me start off with a little bit about me, then I'll give you a little bit about my organization. As I said, my name is Robert Branson. I've been working in the field, telecommunications field, for my entire career, starting out at the FCC. I've worked on the broadcast side, both at NAB, ALTV, and with Post Newsweek Stations, which is a part of the Washington Post Company, owning network affiliated stations. I've been on the wireless side with Verizon Wireless, wireline side with Verizon, and also Fios. And in June of this year, I came out of retirement to work with MMTC. I'd had a lot of experience in the field, including, I should have pointed out as well, being president of the Federal Communication Bar Association. So I wanted to be able to give back a little bit to our community because, I've been in corporate America, did well in corporate America, but it was time to do something for the people we all care about, the communities we all care about, the underserved communities. So I decided to join MMTC. MMTC is nationally recognized policy advocacy organization. We basically work in a section of communication, policy, diversity, equal opportunity. We hold many sessions with top thought leaders, both in government and in the private sector. We also join along with a lot of organizations to put together advocacy pieces. We work very hard on what President Biden just signed, the infrastructure bill. As you know, many of you know, if you look at it, there's a lot of money in the infrastructure bill for broadband, particularly in rural areas and in urban areas. So that's one of the things that we work very hard to push through. We also push very hard for a permanent broadband benefit, which will allow subsidies for people to be able to have service. So I'll leave it at that and wait for the questions, because I think that she's teed up some nice questions, and I want to make sure that we have time to get them all in. So thank you.
Thank you, Robert. And last but not least, Juan Donardo.
No, thank you very much. I would like to thank Rosa and LULAC for the opportunity of joining this amazing panel. I'm all the way from Puerto Rico. I just recently moved to the island, which is my home place, after being 7 years in Washington, D.C. Worked a few years in Congress, then the nonprofit world, and I ended up my last year managing the office of the governor of Puerto Rico in Washington, D.C., and now with this amazing company, Merck, which I feel very proud to represent in Latin America, but based here in Puerto Rico. And I think my past experiences has built up to where I came today. I come from a family of doctors, and they were all, I don't want to say they were all sad, but they were all questioning how I ended up in politics, right? Now that I came back to the science and health area, they're a little bit more happy and they feel more accomplished, right? However, I feel very blessed to represent the company that I represent, managing public policy, communications, and patient engagement. And I think the conversation today is very important. Merck being a patient-centric organization, we're definitely speaking about the diversity in clinical trials, right? We sometimes think that we focus in certain specific races or places when studying the different upcoming medicines, but we have to have a spectrum worldwide to see, right, the different implications that it brings. And specifically here in Puerto Rico, you know, we're a territory of the United States, but sometimes we're forgotten. And one of my main goals is trying to bring more clinical trials to the island and give opportunities to those, right, that unfortunately cannot have treatments the way that all of us in this conversation could probably have. And, you know, the clinical trials giving them an opportunity to see at least see a light at the end of the tunnel. And Merck is investing a lot in the future of not only the company and its workforce, but the future of our patients. So I definitely believe that through the innovation of technology, as we are seeing with COVID, we will definitely see a new era and a new future. So I don't want to answer, you know, to the probable questions that we will be having in the panel, but I do want to thank, again, the opportunity of being here and let you all know that you have a friend here in Puerto Rico. And if there's anything that Merck could be of a bridge to all of you, please don't hesitate to contact me. Thank you.
Thank you so much, Juan Donardo, and everyone for sharing your backgrounds. It's going to definitely make a rich conversation and a very, very important topic. I heard the diversity in clinic and trials. I heard health equity, inclusion, trust. There's so many important aspects of what we're facing today that these conversations need to continue. So with that, I'm going to start by starting with my first set of questions for one for each. We'll start with Mike Ibarra. And the question goes is that what role does the pharmaceutical industry play in the nation's research and discovery ecosystem? And how does industry support the development of breakthrough treatments and cures?
Yeah, absolutely. Well, I mean, first of all, I think we saw that and we see that continue to play out with respect to COVID-19 vaccines and therapeutics. Our job is really never done. And if folks think that we're comfortable with the innovation that we have now, I think the Delta variant and sort of the evolution of the virus and the curveballs that continues to throw at us should be evidence that we can never, ever rest on the innovation that we have today. We saw early innovations. We actually started treating people with things that now we're not using at all. And that was because the evidence, ended up showing that it wasn't helpful. Some of the earliest innovations, though, are things we are still using now, like dexamethasone, which is an older generic product. It's been on the market for a long time, but was found to have a really important therapeutic use in COVID-19. And then I was really excited last year, actually, remember when I used the first dose on a patient I admitted for the medicine that Christina mentioned, which is remdesivir, which is a product that was developed in order to target specifically this product. But again, innovation continues, right? Then we had these vaccines that were developed using a couple of different scientific approaches. And now we have monoclonal antibodies as well, which are sort of immune systems in a bottle that can attack the virus early on, as opposed to some of those other medicines I mentioned, which you use when patients are hospitalized with COVID-19. And now we're seeing the development of antiviral medicines that could be given on an outpatient basis. So you get diagnosed and again, early on, potentially called into a pharmacy. So the innovation that we see in COVID-19 is something that folks are following very, very closely. You know about all these studies that are coming out, you're hearing about it on the evening news, but you just magnify that across all disease states and you see the work that industry is doing across the spectrum of illness. The industry in the United States is really the leader and driver of innovation around the world. And that's in part because of the collaboration that I believe Christina also mentioned, the work that we do in collaboration with the public sector, the partnerships that we have, the investment that our companies make in partnership with government. So I think the United States is really driving a lot of innovation that's happening around the world. And our life cycle is really, really unique. It takes a long time to develop a medicine. Of course, this is also something that's probably been shaped by folks' awareness of COVID-19, the assumption that we can come up with new medicines so quickly. I think that's a really, again, unique feature of the pandemic that I think we can learn something from. How can we speed clinical development in other disease areas? But it's not always going to be this fast because people kind of dropped everything to focus on this once in a lifetime pandemic. Typically, it takes upwards of a decade or more to develop a new medicine. Most of the time, the medicines fail in clinical trials trials. They don't meet the endpoint that they were assumed to have. And it takes a lot of investment, both to study those medicines, billions of dollars to study them, and then also to develop the manufacturing capacity. So it's not just about coming up with the medicine, but also how can you make that medicine? Again, something we've seen play out with COVID-19, because we wanted to kind of know how much supply of vaccine we're going to have, what supply of antivirals are we going to have. So this is all sort of, COVID-19 is a good microcosm for how the industry is the innovation driver across multiple disease areas. And one, kind of drawing it back to this conversation, there are hundreds of medicines in development for diseases now that disproportionately impact racial and ethnic communities. And that includes diseases like diabetes, sickle cell disease, kidney disease, liver disease, cancers. We actually put out a medicines in development report earlier this year called Medicines in Development for Health Equity, something I encourage everyone to check out. If the chat function works, I'll put it in there so folks can look at it. And that, again, is our industry's commitment to addressing the hardest to treat conditions, some of the biggest challenges that we face as a society. So I think I really appreciate the question and being able to sort of tell industry story, which is so critical to driving innovation here in the US as well as around the world.
Thank you so much, Mike. You're absolutely right about the evolution of the viruses require the same evolution of the treatment and other mutants that we see, and now it's becoming a household conversation, and it's always in the news. Not something that was common, before the pandemic. But I think it's important that those conversations do come up, because we need to be aware of what is happening to the world around us, to our bodies, to our families, and to make sure that we're included in those trials and in those treatments. So that's the only way we can build trust, right? So thank you so much. As we continue on this conversation, I'm going to now turn over to Christina. So over 1.5 million people acquired HIV in 2020, with 37.6 million living in this disease. Compared to non-Hispanic whites in the US, Hispanic Latinx people are 4 times more likely to get HIV and 2 to 3 times more likely to die as a result of the disease. According to the CDC, Latinx people are 5 times less likely to seek PrEP than non-Hispanic whites people, despite being at higher overall risk of infection. So higher rates of poverty, stigma, unequal access to healthcare, and racism largely account for these disparities. What is Gilead doing to address these access issues, reduce HIV stigma and misinformation, and ensure treatment is affordable for Latinx communities? It's a long question, but I'm sure you have plenty to share about this. Christine.
Yeah, thank you, Caroline. I mean, the numbers are sobering. When you look at just what you were sharing with the audience, and we're 40 years into this disease, and I think we've learned so much. And now we are very close to a functional cure, meaning that people can live well into their 70s by taking a simple medication every day, but we're not done until that is available for everybody everywhere. And a big part of ending the HIV epidemic is actually by focusing on prevention. And we also make medications for preventing HIV, what we call PrEP, or pre-exposure prophylaxis. And Gilead has 2 medicines, and one of the things that we've learned is that there are places in the United States that are really well off in terms of really managing the HIV epidemic, and then you get into places like in the South, in the border towns, where exactly like you were describing, there's so much stigma, there is so much inequity, and there's so much fear, and you have a number of patients, consumers who could really benefit from information and from going to places that they trust, so that they can get the help and the resources that are needed. And that is from educating people on the disease, on the prevention, on the options, and also support with affordability. So Gilead is really doing, I think a good job, and we're not alone on this. I think there's other companies in the mix. I'm sure Juan Donardo can speak to what Merck is doing as well. Merck was one of the pioneers of actually doing a lot of this work, many, many years ago. So I think it really takes so many of us working together to do this, but it's a combination of meeting the consumers, being very patient-centric and meeting the consumers where they're at. So where do you find the majority of the Latinx community? Well, faith communities are actually a place where you can actually build a lot of trust and disseminate very important education. That's a place where you can actually work on reducing stigma. You can use technology, just like you were describing, in the school district in Chicago, with diseases like HIV. Technology gives you a lot of anonymity. So you can actually, use technology now to chat with a physician and get information about HIV prevention, about PrEP. In looking at, the HIV epidemic in the United States, there's very specific zip codes that are known as PrEP deserts, meaning that, it's very hard for a patient or a consumer to get PrEP because the physicians don't want to talk about it, because it's taboo, because there's stigma, because there's still a lot of ignorance. So we have a great opportunity to use technology to build that bridge and bring people into care and support them where they're at based on their needs. There's also, a number of affordability programs that we have. When you ask a lot of the, PrEP patients, what's your number one concern? What's the number one friction that you have in getting to PrEP? Many of them tell you that affordability is a big issue. So we do have programs like Advancing Access that allows you to, allows consumers to get copay support. We have one specific for PrEP called Ready Set PrEP, where again, consumers can get, copay support. But it really goes to show that it's not just a medicine, it's really that whole ecosystem, right? It starts with education, starts with talking about prevention, reducing stigma, using tools like, digital tools, technology, to bring patients into the mix, working with community organizers, with faith groups, so that it really sort of, you get the idea that it really does take a village. And we're here for the long run. I think we're not going to rest until, we get closer and closer to a cure for HIV.
Thank you, Christina, for sharing. And you're very much right on the mark as far as what needs to be done. It's not one thing, but it's a number of things and a number of organizations all coming together. The affordability is critically important, but without education, it is not going to be enough. People need to be aware, and what options they have, how to go about it, how to engage their families to participate, their communities. And too often we rely on the formal networks to share this information, when in our communities, oftentimes that formal network doesn't work. So the informal communication within the churches, groups like LULAC, with councils that we have throughout the country. I'm part of a national, but also where the work happens is locally in our grassroots communities. In my council in the village of Summit, we're working with the state of Illinois Office of Broadband, bringing more accessibility, affordability, adoption, and use for technology. So, there's a lot of work to be done, and I'm so glad that LULAC is a part of it. So, again, thank you, and we hope to continue to work together. Robert, I would like to continue with you now. As far as the surge of the telehealth industry in remote and medical care in the wake of COVID-19, it has brought a lot of treatment options that were once unconventional, such as remote treatment. What can we do to ensure everyone in the U.S. has safe, affordable, and reliable access to broadband internet and digital resources to take advantage of what it offers, like remote treatments is an example that really just went from hardly not used to almost 100% because of the pandemic. But it needs to continue for remote places and so forth. So, Robert?
Can I take a moment of personal privilege? Because everybody else talked about their medical background. While I'm a technology and telecom guy, my wife's a pediatrician on the front lines fighting COVID. Her best friend is emergency room doctor and runs one of the major hospitals in Miami. So while I don't personally have that background, I do have family that have that background. So I do appreciate all the comments on medical. and I do appreciate all your help in trying to defeat what we've got going on with COVID and other like AIDS and things of that nature and HIV. But let's get to the question at hand, which is basically, we all know communities of color are at disproportionately high risk for chronic illness, not only COVID and nature, but also the basic ones: hypertension, diabetes, and it's not only people of color, but also low income people struggle to make it to doctor's visits, because they can't take time off of work, can't afford transportation. I mean, Uber and Lyft have gone up quite a bit during the pandemic, price-wise. So what has happened? Well, the industries I work in have provided wireless technology, specifically 5G technology. That's higher speed wireless broadband technology, which is allowed for telehealth applications, that permit doctors and patients to do remote monitoring, virtual visits. And I know my wife does that with a lot of her patients. They, instead of coming into the office, they meet on Zoom or other technology. In fact, a Pew survey found that Latino respondents at a rate of 19% were more likely to use telehealth services in the face of the pandemic than white respondents, which were only 15%, which is impressive. You think about that, and as we saw last year with the COVID pandemic, it put a spotlight on the need for innovation in healthcare. For example, in March of 2020, the Cleveland Clinic saw monthly telehealth visits jump from 3,400 over 60,000, which is an increase of more than 1,700%. Amazing. I expect that those numbers, that's 2020 numbers, I expect those numbers are even higher now, and hopefully will continue to grow. So what can telehealth services do for the communities we care about? Well, 5G technology will enable services such as patient monitoring, as I mentioned, even remote surgery through connected healthcare devices. And what else do we do now? With respect to geography, which is often an impediment to patients receiving the care they need, 5G will enable solutions that address difficulty providing specialized service over long distances. In other words, for example, my mother lives in an area where hospitals are very, very far away, remote community in Virginia. This will allow them, once they get the technology there and get the ability and broadband there, to be able to do some things over there. We also have wearable technology that can monitor vital signs. You can use it to do glucose levels, to monitor your heart and things of that nature. And they can act as early warning systems, for both patients and the doctors to be able to monitor and see what's going on. Also, new technology I shouldn't say new, but AI, artificial intelligence, will eventually be able to help doctors diagnose patients quickly and recommend specialized treatment. AI is already making a positive difference in early detection of degenerative diseases and other areas of medicine, including mental health care. So we see, wireless connectivity is providing innovations in telemedicine, patient monitoring, data collection, and this is also providing savings for the system. I've seen a quote of $305 billion annually in decreased costs and mortality rates from chronic illnesses. Perhaps maybe these cost savings will eventually decrease patient costs. I'm not betting any money on that one, but hopefully that will happen. And the 5G economy, is growing healthcare jobs, things of that nature. So what else can we do? Well, what we need to do is we need to educate our communities about the benefits of 5G to urge that the money is spent in our communities, because there's a whole lot of money that was just allocated for broadband, and NTIA and state governments, local governments will be out there figuring out where does that money go, who needs the money. Well, I've always been told the squeaky wheel gets the grease, as they say. So if our communities can go there and do that, if we can get out there and tell people what the money is, how to use it, how to get it, then I think then we can get all these telehealth services. I saw Christina mention the churches. Well, MMTC has a program started this year called Black Churches for Broadband. We changed that now to Black Churches for Digital Equity. Now the same role will go with Latino churches, because there are a lot of Latino churches where, and let's be honest, in many of our communities, we rely upon the priest or the minister to tell us the truth more than we do the politicians around the corner. And that's why we're going to the churches. And I expect that's what we'll need to do in the Latino community as well, to go there to try to get them to encourage their people to sign up to get these benefits. Because, you know, for example, even with the discount, you know, that'll make it easier for families to have these devices in their home, if nothing more than a tablet or a computer. And once we get everyone hooked up, you know, we don't have to have patients going to the local McDonald's to do a healthcare thing, that we'll have broadband in the home. So that's what I'm hoping, that meetings like this can encourage people, educate people what we need to do going down the road. So I appreciate the opportunity to speak on that today.
Thank you so much, Robert. Absolutely, we definitely need to be out there getting the word out, the awareness, the education. And of course, the technology is critical and important, the speed and the advancements of AI. But unless we inform our community, and as you say, the squeaky wheel gets the grease. I mean, LULAC is really greatly known for doing that. We really have to mobilize our community and be wherever our families are, whether it be churches or schools or playgrounds. And definitely the infrastructure is definitely getting faster and more accessible, but it's just the beginning. There's so much more to be done by all of us collectively working through whatever avenues that you know you shared earlier, you know, the churches and so forth. So definitely, I think we're about to see much more of that with the recent infrastructure bill. So thank you so much. Now moving on to Juan Leonardo. According to data from the National Science Foundation, Latinx workers make up 16% of the country's workforce, but hold only 6% of STEM jobs. I can definitely relate to that, being, you know, 1%er for 37 years now. This is indicative of significant gaps in diversity across all STEM fields. What is the biopharmaceutical industry collectively doing? What is Merck doing to bridge the minority gap in STEM and diversify America's workforce?
Oh, and thank you for the question. And before I answer, I want to say, Robert, my mother is a pediatrician, so she could definitely be good friends with your wife. They're given the best in the front line, and I think I pray every day. You know, they're the least protected right now because of, you know, kids being vaccinated. Well, now we have from 5 years old, but hopefully we could bring that a little bit, you know, to the younger folks and the infants. But Carolyn, going back to your question, I cannot speak on behalf of the entire biopharma world. I'm going to speak on behalf of Merck. And I'm also going to give a couple of recommendations, right? I think that everything needs to start from the inside of all of our companies. I was once asked why we were not seeing too many young professionals. And when the person asked me that question, my response was, well, I don't agree with your question, but I think that the right answer to your question is that we are not seeing young professionals because there are not opportunities out there for them. So for us to see young professionals in all of these areas, we need to give them the opportunity. And if we go and speak about the Latino community, unfortunately, we need to recognize that the Latino community is a minority group or a minority, you know, area that sometimes they don't get the same opportunities as the regular, you know, mainlanders or Caucasians, as we could call them. So our companies need to provide the opportunities not only through grants, sponsorship, donations, but also through programs that we could open the door when others don't open them. And I can speak when I used to work in Congress, my former boss, who is today the chairwoman of the Congressional Black Caucus, Joyce Beatty, she was all into STEM and giving the opportunities to little girls and little boys, you know, starting from, you know, elementary school and providing them with summer camps and programs that could definitely move, you know, the topic of STEM. Because if we don't inculcate them with the topic and if we don't give them the opportunity or the experience, how are they going to know, right? But coming back to Merck, I think one of the best practices that we've seen or that I've seen while I've been here in the company is the employee business group. It's called the EBRGs, and each EBRG needs to have, what's the right word that I could use? Needs to have a vocation or a purpose of why they exist. And so, for example, the four main EBRG groups at Merck, it's the Rainbow Alliance, it's the next gen, it is the veterans, and it is how can we join the community? So it's called the Community Relations EBRG. And so, for example, I am the lead sponsor in Latin America for the Rainbow Alliance EBRG, and our value or our sponsor, it's for STEM. So right now, all of the sponsorships or all the donations that the EBRG groups in Rainbow Alliance of Latin America does or gives is for any organization that it's providing opportunities for kids for the STEM world. Right now, there's an organization in Washington that is dedicating themselves for STEMs in Puerto Rico, which is called Friends of Puerto Rico. So they join the public schools and they provide extracurricular activities for this students where they could see, you know, different topics or opportunities that they're not seeing in school. So we go back to the core value of corporate social responsibility. So if we at some point want to see this in our company, we need to invest in the future generations, right, on where we would like to see them. One of the programs that we're doing here in Puerto Rico is that we're not waiting until they are in college. While they're at high school, we're doing a kind of an internship, but it's more of a shadowing program while they are in 11th grade and 12th grade, and they have demonstrated that they have an interest in engineering or in the pharmaceutical world, or even in the, you know, the regular medical practitioner world. They could apply and then we could guide them, because as you know, all pharmaceuticals, we have a chief medical officer, we have a chief financial officer. So we also need to see that within our companies, we have all the different roles. Look at me, I'm managing public policy. So, you know, so we definitely need to understand that it doesn't matter if it's in the pharma world or any other spectrum or any other area, there's a specific role in that company that aligns to all the different industries out there, right? So we definitely need to give the opportunity. So it goes back to my main point. We need to give the opportunity so that the next generation or the upcoming generation definitely gets to know what they will like. It also provides them the opportunity that they could say today that they want to be a doctor, but if they don't experience how it is, and before they get to college, they could probably decide, well, that's not really what I wanted. An example that I could say is when I was in high school, my mother wanted me to be a pediatrician, and she was forcing me, and she said, no, you got to go to medical school. And I knew inside that I didn't want to be a doctor. So I went to a program called the People to People Leadership Program in medicine at Georgetown University. And you got to be right that my first week in that program, it was awful, because although it was amazing for all the students, for me, it wasn't the program that I really wanted to be. But it was because of those opportunities that I had that I reaffirmed, right, what was my direction, or where I wanted to be. So at the end, companies and marketing is doing it very well. We have to bring the opportunities. And also when we give these opportunities for them to see if they like it or not, we're training them. And that's the workforce that we want to hire when there's an opportunity, because we already invested in their education and the opportunity. And when there is an opening, we already have them trained, right? You know, it all works out. So at the end of the day, I'll answer the question. For the community, the Latino community, to be involved in STEM, we have to give the opportunity. We need to invest in nonprofits. I'm a true believer in nonprofits. I was a director of a nonprofit, so I do know the amazing hard work. And sometimes our companies, because I have to say it, they put a lot of bureaucracy and they say, well, we could give money to this program, but we cannot pay the administrative side of the program. But if we don't pay the administrative side of the program, how is the program going to work, right? So we definitely need to educate our companies and what is out there, where are the needs, and where we could impact. And at the end of the day, it will all work out.
Juan Donardo, thank you so much for saying what those words of wisdom. You will become my best friend, because I'm launching my nonprofit and I could use all of that guidance and approaching corporations that, from what I understand, so little is invested in our Latino community. Something like 2 or 3% total philanthropy goes to Latino communities, and our nonprofits need that support, not only in the services, direct services, but in, like you said, the administration, the foundation, all that. You were going to say something, Juan?
I was going to say something. When I was hired in my position, it will be a year now in January. The first thing that I told the hiring managers was like, I have never seen this position in which you're hiring me from. So it means that I kind of have to build the airplane as it's flying, right? And she was, you're absolutely right, right? And under my charge, I have Colombia, El Salvador, Honduras, Panama, and Puerto Rico, but mostly concentrated in Puerto Rico because of my expertise. And the first thing I told the hiring manager was like, if you give me an opportunity to hire someone to my team, it will be a patient engagement associate director. And she was like, what is that? I said, I want to bring a former executive director of a nonprofit to work with me so that they understand how a nonprofit works, and they could educate the company on where is it that we want to invest and how would that investment come back to the company. And you believe me, I got the former executive director of Susan G. Komen in Puerto Rico because Merck, one of its mainland, it's oncology. So if we're impacting the patient's life, and I cannot talk about products, I cannot talk about products in any of my conversation. So I just think that I'm impacting the entire oncology patients. It doesn't matter if they use my product or not. But at the end of the day, we're impacting the clients of ours, our stakeholders. And at the end of the day, we're impacting the community because through our support, and this person, she's guiding them in the actual way in which the patient has to go and also in which the company has to go. Because right now a patient is diagnosed with cancer, and what's the first thing that happens? Access barriers. You know, their insurance do not approve it at the right time. And so a person like her tells Merck, hey Merck, you need to invest here because there is a barrier that we could help through this nonprofit. And so at the end of the day, you know, it works out. So I invite you all, you know, to bring this knowledge to your company if you really want to help the community. Because something that really affects me, and it came from Washington, was that people talk, and they put their suits on. But actually, when did they put their hands in the community? When are you there to actually see the needs and then bring your suit to your people and tell them this is what we need to do? So we sometimes need to walk the talk, and we sometimes need to have more of a vocation than the actual desire of a title. And so I do believe that this panelist right here do agree with me. You know, we're here right now. We take time out of our busy schedule because we do have a role in the community to impact and bring our voices to help them.
Thank you so much, Juan Donardo. And it sounds like what you, having been in DC, really helped you to go back and make it authentic, make those voices real in the companies from those that they're serving, as opposed to just, like you said, in a back room or in a lab or setting or whatever. You know, bringing people that really have the direct experiences to the table is really the right approach. So it sounds like they're listening, and you're making great contributions at Merck. So back to a second round of questions. I'd like to begin again with Mike. So Mike, the rising cost of healthcare in the United States translates into higher insurance costs, under-resourced hospitals, and a lack of access to affordable medicines for underserved communities. How is the industry working to ensure that all Americans have access to innovative treatments and therapies and advanced health equity for historically underserved communities?
Yeah, well, thank you for asking that question. I think that's really one of the most challenging things that we're going to be working on, you know, we've been working on for the last several decades, and we're going to be working on it in the years moving forward. I think one of the most critical things is to really appropriately diagnose the problem and make sure that the treatment matches the diagnosis that you have. That's really something that I approach in medicine, of course. You know, if somebody comes in with abdominal pain and we work them up and we diagnose them with appendicitis, then we set them up for surgery to have their appendix taken out. We put them on antibiotics. You know, if somebody is diagnosed with appendicitis and then we take out their gallbladder, that's obviously the wrong thing to do. And in the same way, if we are looking at this problem of cost and access, we need to make sure that, you know, we're diagnosing the problem right. You know, what is the key problem that consumers or patients are experiencing? And then is the treatment going to be the right thing for the patient, so that we're sort of making sure that, you know, big legislation or, you know, big pieces of regulation are actually appropriately addressing the problem. And one of the things that I'm worried about, that I think we're worried about, is right now, I think we do have agreement that as it pertains to medicines, in fact, too many patients can't afford them. They are out of reach for too many patients. And the solution that's being addressed is talked about more as a bumper sticker, allowing the government to negotiate, that doesn't necessarily get at the out-of-pocket cost that an individual is going to face. In the same way that we have to diagnose the problem problem in medicine, we got to diagnose the problem and treat it appropriately from a policy standpoint. So the key thing is making sure people have coverage, right? So if individuals don't have insurance, chances are they're going to be able to afford very, very little of their healthcare. I will say from an industry standpoint, our industry is really committed to addressing the needs of individuals that are uninsured. And a lot of companies have programs to help patients afford their medicine, particularly if they're uninsured. Now, we know the number of uninsured Americans has gone way down in the last decade, which is a really good thing. But I will say that pharma has a tool called the Medicine Assistance Program where you can go on and look. And if you have an uninsured patient, which I occasionally have in the emergency department, you can get them help through tools like the Medicine Assistance Program. It's unlikely that an uninsured patient is going to be able to afford almost anything in our healthcare system. Certainly not the emergency care that they would be seeking if they were seeing me. Potentially not the medicine, but in some cases, again, there are assistance programs through companies for branded medicine. And then there are, of course, low cost generics. So coverage is really important, but the key thing is quality coverage. So just because an individual has health insurance doesn't mean that they're going to be able to afford the out-of-pocket cost associated with their benefit design. And so too many patients that I see, in fact, I don't see that many patients that are uninsured anymore in the emergency department. What I see is sort of this gap in terms of the quality of coverage that a patient has. So they might have health insurance, but they may have, say, a $4,000 deductible. And there are very few Americans that have enough money to cover a $4,000 deductible. So if you come to the ER, you get diagnosed with something, I can put you on a medicine that keeps you out of the hospital. And they have a $4,000 deductible, it might be better for them financially to get admitted to the hospital than it is for me to keep them out of the hospital and prescribe them a medicine that might keep them, that could keep them safe at home. That is completely backwards for what is best for the patient, but that might be the financial incentive in place. So cost, access, benefit design is so critical. That's why we're really engaged in the policy discussion right now about how we can make medicines more affordable for patients. There are a lot of things that we're advocating for at the federal level, some of which are at play, like instilling an out-of-pocket cap in Medicare Part D. Right now, there are provisions being talked about in the reconciliation bill that would put an out-of-pocket cap at around $2,000, smooth out the benefits so patients would only have to pay about $167 per month if they're on medicines. That's a really good improvement for individuals. But that's just in Medicare Part D. And there are plenty of other provisions in there that would negatively impact the ability to develop new medicines. So bringing those innovations that we see in COVID-19, how we can advance medicine development in other disease areas. So all of these questions are, this is, first of all, a really important question, one that we are so involved in getting right. And I just can't emphasize enough how getting it right is really critical to making sure, A, if we're gonna try to treat a condition, which is high out-of-pocket costs or patients unable to afford their medicine, that we're doing the right treatment, that we're making sure we're addressing the problem and we're not creating any side effects or collateral damage from that. And so happy to talk more about that, but maybe I can just pause and turn it back to you, Caroline.
Thank you so much for sharing that. As you're talking, I'm thinking that it is much more complex. It's not black and white. It's not between insurance and non-insurance, between having access or the quality of the access to the care. I mean, really, there's a lot of gray areas, and just because you have insurance does not mean, like you said, you can have quality insurance, quality care because of the out-of-pocket, deductibles. So it really requires a lot of knowledge and a lot of support, and hopefully you can reach out to LULAC and we can collaborate as far as how do we communicate effectively to our community so that they know their options, and it's not so simple as you have it or you don't have the insurance, do you have the care, you don't have the care. So there's really a lot more conversations about this. So again, thank you for sharing this. And then hopefully in the Q&A, we can keep going with the conversation. So now turning over to Christina. People of color are significantly underrepresented in research and clinical trials, as you were sharing earlier. How can industry stakeholders work together to increase participation by racial and ethnic minorities in research and clinical trials to ensure drugs and vaccines work for everyone?
Great question, Caroline. And, I think this is an area where we absolutely can do better. Again, it's multifactorial. When you think about why there's so few patients, brown and Black patients in clinical trials, sort of have to take a look at a number of things. One is, well, first I would say, where are the incentives? Is the incentive, speed to patient? Then that has to be representative of the diverse communities where we all live and work, and ensuring that we are driving that diversity. And I think, frankly, a partnership between industry, FDA, pharma, to continue to sort of drive that diversity and hold each other accountable in driving that diversity in the trial is really, really important. Then you look at who is conducting the trial in terms of the investigators, right? And do we have enough Black and Brown investigators? I would say no. So that goes back to the STEM question. That goes back to, how do we drive more Latinos, more Blacks into STEM education so that we have the doctors, the nurses of tomorrow, so that we have the scientists of tomorrow. Then you think about, who does that patient trust? And chances are they're going to trust their own doctor, right? So when you think about, African-American doctors say they treat the majority of African-American patients, there's so much data that talks about that trust, right? So ensuring that there's an alignment between that patient's physician and the investigator, or having more investigators that are community physicians. So, there's a lot that we can do. And I think, again, is multifactorial. You have to think about, how do all those pieces come together and what are the incentives? And there's one piece that I think it's where we really have an opportunity now is to use technology to bridge more diverse patients into clinical trials. When you think about, let's say a trial requires, 14 office visits, right? So if you are, a woman in your 40s, you have, rheumatoid arthritis, and you have cycled through therapies. Now, a clinical trial may give you an opportunity to actually find better care and a medicine that may actually be transformational for you. But you're a mom, you're taking care of your parents, you're a wife, you have a job. There's no way you can make room for 14 visits, right? So how do we use technology to bridge that? And maybe as opposed to having, that person going to the clinic 14 times, maybe they go 7 times and the other 7 visits are done remotely. So exactly like Robert was saying, you're using technology to sort of bridge the gap and ensure that you can increase that participation, and you're being very patient-centric and meeting the patients where they're at in terms of their needs. So I think there's, again, a lot that we can do, and one area that I am very passionate about, because I think we can certainly do better, and we need to be better together, as, public sector, private sector, and I think all of us that have a stake in the healthcare ecosystem to do better for patients.
Thank you so much, Christina. Absolutely. There's a lot of work to be done in that, building that trust. And I think together we can certainly get there. So now turning over to Robert for his second question. Due to the lack of understanding, exposure, and role models, Latinx and members of underserved communities are rarely encouraged to pursue the many opportunities offered by industries focused on innovation and new technology. How can we change this? How can universities and businesses play an active role in promoting diversity and innovation and encourage people of color to pursue science, technology, engineering, and math degrees and careers?
Thank you for that question. As I was thinking, as you were talking, I was thinking back, I want to say about 20 years ago, I was a trustees member at Simmons College in Boston, which is actually, Simmons University. The name has changed, but that's primarily a women's college. And we were talking then about how to encourage the women that we were educating to look at STEM careers. So fast forward, we're still talking and the dialogue is still going. And there are a lot of companies out there who are trying to push it, because these companies need the employees of the future. They need someone to create the technology of the future. They need someone who can understand AI, who can understand how to make telemedicine work better. And many of these companies are pushing. And many of these companies, I should say, to their credit, had programs. When I worked at Verizon, for example, they had competitions and things of that nature to help spur people doing it. I know some of our trade associations like CTIA have also been out there trying to encourage people and going into schools and educating them and having science fairs and whatever the equivalent of that is nowadays to do it. But, I think the key is, though, until we get the broadband that we need in the home. In other words, until we get the technology in the home where people have the ability to go on the computer at home and look up Verizon, look up AT&T and see what programs they have and be able to use the computer at home to apply for those programs and do things of that nature, you know, we won't get there. I think we're getting there now. I think now with what was just signed, it should spur that, and we should have a lot more capability to do that. I was sitting with at a wedding probably about a month ago, and I was sitting with a guy who was an electrical engineer. He was telling me how much you can make being an electrical engineer these days. He said, you know, kids don't know about that. You know, you go to college 4 years, graduate with a degree, and you know, you're making close to 6-figure salary. You know, I went to law school and you know, and spent probably a few years before I made a 6-figure salary. And these kids are coming straight up, but some kids don't have, people in our community don't know that. They're not encouraged. And why aren't they encouraged? I think your question pointed it out. There really aren't the role models out there. We look at the guys shooting a basketball or tossing a football. You know, the kids, how many of them watch the movie Hidden Figures and see, you know, the Black women who were in that movie who did amazing. I mean, truly amazing things when you think about when they did that, you know, and but those stories don't get told enough. I mean, there are tons of other stories out there, you know, that we need to encourage and our youth to see those role models. And like I said, while the questions were asked when I was a trustee at Simmons, frankly, to a certain degree, that's too late. By the time they get to college, we actually have to start at an earlier stage, you know, when they're in high school, or even maybe before that, giving them ideas. I didn't even know if they do these science programs like when I went to high school. We had a lot more going on there, and hopefully they are doing more. My daughter went to high school. She was more liberal arts. I did not convince her to do STEM programs, but she's doing good. She works at the ACLU, so she's fighting on a different way, different cause. She's helping people out through the ACLU. But a lot of, you know, we need to do more, and I think we need to find the role models. We need to get the Mae Jemisons, you know, to come to the more schools and talk to the kids. You know, we need. I mean, there's so many others out there, you know, in science, the doctors and other scientists that can show kids that they, you know, if you can see someone who looks like you, who can speak your language, you're more likely to listen to them and maybe try to emulate them. So I think that's the key is finding those role models. And like I said, and using the resources we have, because most of the major technology companies out here have programs. You just got to find them.
Absolutely, and I think you hit on various aspects of, you know, what we can each do our part. Certainly, corporate is you know, there and needs to do more, but they're not the only ones. I mean, there are a lot of small businesses. Most of the workforce is made up of, you know, small businesses hiring, and so small business like mine. You know, I'm in technology. I changed careers. So I started business. Then over the years, I started my business. I changed to technology, but I connect with my local high school. You know, my university. I was a trustee as well, all women's college as well. And so in my case, I changed careers. So if you didn't get it in high school, college for whatever reason, doesn't mean you can't later, you know, change and adapt. And then secondly, you know, the small businesses can do a lot themselves. So we grow our own. We hire them right out of high school or right out of college, and we mentor them, we job shadow them, we provide apprenticeships. And, you know, today out of our 25 employees, you know, half of them are coming from our high school that we're grooming, and we either find them after college or through high school. So there's so much to be done within our own communities, and we need to talk more about that as well. You know, not rely on any one source or sector to do the job. So again, thank you for sharing that. We're moving on to our last panel, last question, and then we can get to Q&A, because I'm sure there's going to be lots of great conversations there. Going to Juan Donardo. Since most chronic health challenges disproportionately affect minority and low-income populations, It is crucial that Latinx are able to use telehealth as long distance virtual healthcare and have access to patient and professional health related educational resources. How do we ensure Latinos are able to take advantage of the limitless possibilities emerging technology offers? So Juan Leonardo, please.
Oh, and thank you. Thank you for the question. And before I answer that, I would like to say, Mike, thank you so much for the support the pharma is giving us. You know, right now here in Puerto Rico, we have a lot of disparities when it comes to health care and how Congress, you know, it's seeing things down here on the island. And what you were speaking about, the maximum out of pocket, is very important. For all of you to know, if you don't know this, right now, if a nonprofit gives a patient the amount that they need to pay the maximum out of pocket here in Puerto Rico, that money that they receive from the nonprofit is not counted for their MOOP, for their maximum out of pocket. So they get the treatment, the patient starts the treatment, but that maximum out of pocket still keeps adding up and adding up and adding up, and the patient will never be able to pay for it. So it is awful, because if a nonprofit is giving that money, whichever nonprofit or whichever organization, the insurance down here are saying, nope, that money's not coming out of your pocket. You still need to pay that money. So it doesn't make sense. There's a lot of disparities down here, and your organization, Mike, is helping us a lot, not only with the Medicaid in the federal government, you know, making sure that Puerto Rico receives the federal Medicaid assistance program percentage as we need it down here. But I just needed to say, because we definitely need to congratulate those that support us. So here, I wanted to say that. So back to you, Carolyn. I think we need to educate the Latino community. Now I put it on us, right? Because sometimes the Latino community, we fight because we need this, we need that, but where do we put the effort, right? I could take the example here in Puerto Rico, the abuelitas and the abuelitos, sometimes they're not sick and they make it to the doctor's office just to speak with them, you know? And it doesn't give them the opportunity for the actual patients who are sick to get an appointment, because they're just into it, you know, of going to the doctor. They live for it, right? And I think the Latino community, we're more of a people's person, and we like to go to the doctor. But we definitely need to educate, you know, that if there's no other reason of why going to the office of the doctor, we should definitely use the resources. Sometimes they just don't know how to use it, you know. We need to start promoting more tutorials, you know, for all levels of how to use the telemedicines. Sometimes it's even the doctors. And, you know, as much as I want Puerto Rico to be the #1 innovative place in the world, you know, right now here, doctors, many of them don't even have electronic records, you know? So, you know, and my mom, I could use her as an example. She still has regular paper records, and I consider her young, but it's not inculcated here in Puerto Rico. In the area that she has her practice, that's not a typical lesson. And then you have a CVS and you have a Walgreens that says, hey, doctor, can you please send me the prescription online, or however it works? But they don't have the infrastructure down here for those doctors to use it. So it's a little bit complicated. So I'm trying to use the example of Puerto Rico on probably how it's happening in the mainland. You know, we first need to educate. I have not seen any campaign out there of telemedicine. We need to do a campaign that approaches the people and said, if there's no need for you to go to the hospital, stay home, and this is the different resource. We need to partner with medical insurance. They all have apps where you have your, you know, medical cards and your iPhone. Well, have them something simple for you to log into an app like Georgetown University does, or GW. I remember that my insurance partner with GW, and I had an app and I could do all through there. Here in Puerto Rico, I have nothing of that. Here in Puerto Rico, you definitely need to go to the doctor, right? Because the only few doctors that are doing telemedicine are the plastic surgeons, because if you have the money to pay a plastic surgery, you probably know already how to use technology a little bit more, right? But unfortunately, we need to start with the basic, which is education. We need to start with demonstrating to them, you know, it's very beneficial. And we also need to tell doctors that they need to invest a little bit more and, you know, in promoting telemedicine, and especially to the Latino doctors, because the Latino doctors do like, you know, receiving the patients in their office because of that contact. And And let me correct myself. It is important, the physical and the personal, interaction. Sometimes the patient just needs to speak to the doctor and they're already feeling better, right? But in the times that we're living, we need to prevent. And the way for you to prevent, you need to educate. So I put it more on us, the Latino community, that, we like things our own way and we don't immerse ourselves with, with innovation. And we just need to hop on the boat of what's happening today with COVID. And we definitely need to, know to determine when is it that we have to go and when is it not. And the doctors also need to put that pressure.
Great points you're making, Juan Donardo. I always believe that we have to start with us, our own responsibilities, and not always on everyone else. So if we set the example and models for that, I think that things will keep evolving and everyone will be working together. And I love what you said about a campaign to promote telehealth in the Latino community. So I'm going to be calling you up about collaborating with LULAC and how we can do this with our councils across the country, because definitely there's so much. And you're right, it doesn't have to be all telehealth. I mean, it's important to see the doctor, but there's so many times when you can't see the doctor or you don't need to see the doctor, and we need to know about those options, so definitely a campaign around telehealth. You're definitely on my list of calls to, and anyone else here that has shared so much. I hope that you're open to those ongoing conversations. So thank you so much. I've learned so much today and from each of you, and it's time to turn it over to the Q&A. I'm sure there are going to be great questions coming up, and Rosa will be joining us to help in managing and monitoring those questions. So Rosa, would you like to begin with the Q&A session with us?
Absolutely, and thank you everyone for this great conversation. So this question can be for any of the panelists, whoever wants to take this question. So the question is, there have been a number of policies, legislative proposals being discussed by Congress and the administration right now to lower cost and reform our healthcare system. What are some policies which could diminish access and threaten availability of medicines for underserved communities, including how Hispanic patients, Hispanic patients, and widen disparities for underserved communities? And a sort of follow-up question is, what are some common sense reforms that can help ensure Hispanic patients benefit from biopharmaceutical innovation and receive the care they need and deserve?
Yeah, I'm happy to jump in there and sort of kick it off. I kind of got to this with my analogy about getting the diagnosis and the treatment right. I think this is something we've been following, very, very closely, because the Build Back Better Act that's being talked about in Congress includes some provisions that would impact our industry. Actually, a number of provisions that would impact our industry. Unfortunately, not always looking holistically at how we can just simply improve access and affordability for patients, but it is being looked at as a way to sort of generate revenue for other priorities. Our major concerns with the provision have to do with the way that the government would sort of set the price of medicines for many innovative medicines in a way that's kind of a take it or leave it type of approach that would lead to fewer research investment dollars, less incentives to do follow-on research. One of the really unique aspects of medical innovation is that it's not always the first innovation that is sort of immediately the big advance. COVID-19 is a little bit of a reverse of that. Sometimes for cancer, for example, you might have one innovation that sort of opens the door to future combination therapies or investigation of that treatment in maybe a rare disease or looking at it in pediatric indications. And all of that research is time consuming and very costly. And so Congress over the course of many years has put into place incentives to encourage that type of research. And this kind of bulldozes over that and takes away a lot of those incentives and has a really blunt approach to price setting that's concerning to us. At the same time, as I mentioned before, there are some good provisions like the out-of-pocket cap and smoothing for beneficiaries that would be really, really good. So I think, again, there are ways to help patients get the treatment right based on the diagnosis without kind of bulldozing over innovation. So the other aspect of this is it's a very, very complex ecosystem. We make medicines, we do the research and development to make those medicines. The incredible work of scientists at Merck and Gilead, for example, spend many, many years developing those meds. But then at the end of the day, it's intermediaries often that take the medicines and ultimately design formularies around them. It's insurance companies that set the out-of-pocket prices for those medicines that patients pay. So once they leave our factories, the supply chain has a huge impact on what patients ultimately pay. And unfortunately, the package really doesn't look at all at some of the dysfunction that's occurring. So failing, if you're going to do a big kind of reform of our system, failing to look at the role that pharmacy benefit managers and health insurers pay and forcing patients to pay more than they should for their medicine, that's a really kind of big missed opportunity. So I think that we're actively involved in continuing to provide our perspective on this legislation, and I think that's ultimately where that's ultimately going to play out in the next couple of weeks.
Thank you, Mike. We have time for one more question, and the question is, COVID-19 sparked much needed dialogue on the importance of healthcare diversity, but we must be mindful to not push meaningful progress on this matter, aside once the pandemic abates. What efforts are needed to ensure our medical system includes a greater number of minority healthcare providers, caregivers, and researchers? Again, this question is for any of the panelists. Christina, do you want to take a stab? You're on mute.
Sorry, reflecting on the conversation we had over the last hour, I think there were so many lessons from the pandemic that, and even reflecting on HIV, so many lessons from HIV that helped inform COVID. And I think ensuring that, that healthcare systems, I think when you look at the IDNs, for example, healthcare and politics are local, right? People don't really travel more than 30 miles to consume healthcare unless they're going into catastrophic care. So when you think about the IDNs in the United States, and these are group organizations, right? Like when you think about, I live in Los Angeles, UCLA, Cedars-Sinai, USC are some of the IDNs that are in my neighborhood. So ensuring that we have physicians, nurses, practitioners that sort of look and mirror the communities where we live. I think they have a really important role to play. And as consumers of that healthcare, we need to hold them accountable. As a Hispanic woman, I go into UCLA and I want to see Hispanic physicians, and sort of raising my voice and asking that. I think it's really important. And then for the IDNs to also do their part. There's so many people in the healthcare system that play a role, and it's not just one, I think one person or one entity cannot fix it. I think it's all about partnerships and working together and seeing, who can have the most impact, who can dive in. Another piece of that is, when we talk about telehealth, there were so many reimbursement emergency measures that were taken to reimburse telehealth visits. And I think expanding that way beyond the pandemic is going to be, super important in driving access to care as well.
Thank you so much, Christina. Wow, what a great conversation. This almost hour and a half has gone by so fast. And I think I see a common thread, the importance of education. Cost is not the only issue, it's important, but there's much more to it. Speed of the internet, access to it. And of course, with what you just said, Christina, partnerships and working together. I always use this term, and many times in my emails, stronger together, because we definitely can do a lot individually, but a lot more together. So with that, I'd like to now ask everyone to give their brief final thoughts so that we can, how would you like to leave our audience with based on this rich conversation? And so I'd like to begin with Mike, please.
Sure, let me come on. Have to come off mute. Start where we or end where we started. Thank you so much for the opportunity to participate in this conversation. Obviously, appreciate the work that Alvanza and LULAC are doing to tackle these critical issues. And I guess just to kind of wrap up our perspective, I think that we have so much that COVID-19 has taught us. And one of the things that I try to think about every day is, what has happened in the last 1.5 to 2 years that we can really use to sort of build, a better, more robust ecosystem for research so that we're, trying to get at some of the challenges that underrepresented minority communities faced early on in the pandemic. Like I said, I just, I can remember the faces of the first people that I saw with COVID-19. Many of them didn't speak English. Many of them lived in multi-generation housing. They were communities of course, that since then has sort of spilled out, and now it's affected everyone, right, in every community, every pocket of the US. But the real challenge with the fact that it impacted Hispanic, Black and Brown communities is that early on in the pandemic, we knew so little about treatment, how to treat patients, that it was really just a tragedy that they were the first kind of impacted, and we had so little, kind of medical knowledge on how to provide the treatments. Now we know so much more. So how can we take those lessons learned and ensure that we're building a better, kind of more robust ecosystem, both from a healthcare delivery standpoint, but then also from an R&D standpoint? And I can say that our industry is very, very committed to doing everything that we can. I mentioned some of the initiatives. I left off a many number of other things, but there's incredible work happening from our member companies, like the two that are on the Zoom here today, and really appreciate all of that. And look forward to continuing the dialogue. So thanks again for convening this.
Absolutely. We definitely look forward to continued dialogue. Just to make it also, to continue and have everybody an equal voice for the final thoughts. If you can make it brief, we'll greatly appreciate it. Christina, if you can follow.
I think there were so many lessons too about the human experience and the cultural impact that, where we all came from had on the pandemic, like Mike was saying, like how people live together in multi-generational households, trust of the system, et cetera. So I think sort of not losing sight of that, sort of like the human experience is so important, and that's got to drive better partnerships between, public and private sectors.
Absolutely. Continue to partnerships. Absolutely. Robert, your last thoughts.
I'll keep it relatively brief. Work with people in your community. If you know something, let make sure other people know it. Take advantage of what we have. There are organizations like mine, there are organizations like LULAC, Avanza. Go to their website, see what they're doing, pass it on, because all these organizations become stronger if we have more supporters looking to see what we're doing and encouraging us, and also passing the word on to others. We have strength in numbers, so always remember that. The more support we have, the more we're able to do in the community. Thank you.
Thank you so much. I couldn't agree with you more. Juan Leonardo, your last thoughts.
No, first of all, I want to say thank you so much again for the opportunity. My last thoughts are, we are privileged here in all of the positions that we are. And now we need to take that privilege and we need to make it an opportunity. And I always bring the example that we made it to the penthouse because we're fortunate with what we do. Now we need to bring the elevator down and bring more people up to where we are, by providing them opportunities and by providing them the resources that we need. If we want to see change, it has to start with us, because we could give here the best speech. We could be the speechwriter of Biden, Obama, whoever you want to be the speechwriter, but we need to put the words into action. And I think we all here have the resources and the places to connect the bridge of those needed, and we'll definitely see the difference.
Well, thank you for saying that. And opportunities definitely is where it should start and continue. Without an opportunity, we're not going to be at the table. We're not going to form partnerships. So what a wonderful set of thoughts that everybody's shared that really can give us a lot to think about and go back to our communities and do some great work and build those partnerships that we already have, like with Avanza and LULAC and all of you. I'm going to turn it over to Rosa to close and just thank her for the invitation, and it was an honor and a pleasure to be here with you.
Thank you, everyone. And thank you to all of our speakers for sharing your time and your expertise with us. We have heard today that we have a lot of big challenges, but also great opportunities. I know this will be an ongoing conversation, and I look forward to continuing to collaborate with all of you on these critical issues. Again, thank you, LULAC, for your partnership. It's a pleasure to work with you, as always, Cindy Benavides. And finally, thank you to all of you who made time to join us today. I know these are busy times, and it's wonderful to know we've got such a diverse community committed to engaging in this important work. Thank you again, everyone, for joining us, and have a great evening.